Bismillah ar-Rahman ar-Rahim. Sorry for the delay. It's our pleasure to have you with us today in a very nice and applicable topic for a clinician. And I think it's a challenging topic. And I'm very delighted with the I'm pleased with the title. It's a NeuroConnect. Welcome everybody. بنرحب بجميع الحضور. بنرحب بالدكتور زياد الشامي من السعودية. مرحبا دكتور زياد، أهلا بيك معانا. It's my pleasure to introduce Professor Demos from Greece. He's an associate professor of neurology, and he has a very rich CV and very long indeed. It's very rich and long. So I'll pick that he's very interested in the topic of headache and multiple sclerosis. And this is the purpose of our webinar to put the differential diagnosis and the link between both diseases. We have a lot of especially radiological conflict. A lot of patients with migraine has been diagnosed to have MS and the opposite. So it's my pleasure to introduce Professor Demos, and he's going to speak about the differential diagnosis of migraine, between migraine and multiple sclerosis. Please, Professor Demos.
Thank you very much indeed for your very kind invitation to be with you this late evening and share with you some very important, according to me, topics. So I was really very pleased when you offered this title, because it's really very clinical relevant, and we are seeing everyday patients who are suffering from both conditions, and the clinical dilemma, which was the trigger of the other one, always exists in an active neurologist. So I think my presentation or my conversation with you will last around 30 minutes, but please feel free to interrupt me when you have a question, and I would prefer to have a real conversation instead of a weak talk and a sterile talk. So I will start sharing my presentation. And first of all, I'd like to secure that everything I'm showing is visible and you can hear me. So please reply to me that I'm not talking to a weak computer. Can you hear me?
Yes, the voice is clear, Professor. Yes.
All lines are visible.
All right. So let's proceed. So the differential diagnosis between multiple sclerosis and migraine. This is the agenda. So I will say a few words, not really few, but about the co-prevalence of migraine and multiple sclerosis, because for years we used to believe that there is indeed a high comorbidity between multiple sclerosis and migraine. And still, if you look at the literature, you will find quite a lot of papers declaring that there is indeed a real comorbidity, meaning that the prevalence of migraine is much more higher among patients suffering from multiple sclerosis than to those that do not suffer. And I will show you data proving that this is not true. then still the question is alive. We have to answer in those few cases, they are not so few, there is a co-occurrence of both disorders if there is a real etiopathogenetic link between those two conditions. I'll try to answer another question. What happened when headache is the first manifestation of multiple sclerosis? According to my experience, this is extremely rare. And the most important of my presentation is this one. What are the white matter lesions that are associated to migraine or to multiple sclerosis? In other words, what are the characteristical architecture and location of migraine-related T2 lesions and multiple sclerosis T2 lesions? Then I'll say a few words about the management of migraine in the context of multiple sclerosis, and I will end. All right? All right. So those are my disclosures. Affiliated to the National and Capodistrian University of Athens. I was past president of the European Headache Federation, current president of the Headache Society, and co-chair of the headache panel at the European Academy of Neurology. I'd like to remind you some very important data showing or even proving that migraine is really a very disabling disease. It's not a condition, it's a disease. And in terms of epidemiological metrics, you can't believe it, migraine is much more disabling disease than multiple sclerosis. Here, you may see the 5 leading causes of years lived with disability in 2016 as the Global Burden Disease Project published in Lancet 2017. You will see that migraine is the second disease after the low back pain, following by hearing loss, iron deficiency, and vitamin or iron deficiency as well. So that's showing that our civilization currently is suffering from pain, whether that comes from the body, low back pain, or the head. And if you go here to the other cartoon, you will see the 10 causes with the greatest disability in 2016, with a great prevalence, sorry. So you will see that the teeth disease is the most prevalent condition among our civilization, following by tuberculosis, and then essential type headache, hearing loss, and at 6th rank is migraine. So it's really very prevalent. All right, having said that, and taking into account that migraine ranks as the first condition with the greatest disability in people younger than 50s among all medical conditions in the world, please pay attention to that, is the first cause of disability in people younger than 50s among all medical conditions and diseases, migraine, because it's very prevalent. And because the disability, the ictal, is huge during the attack. So why we're discussing this topic this evening? Why we have this clinical dilemma, whether there is a link, etiopathogenetic, between multiple sclerosis and migraine. it's of course because we have so many cases, patients are suffering from both conditions. But I'll try to answer that one. Do we have good quality data showing that there is indeed a comorbidity between two diseases or not? Another very important piece of data is this one, that the prevalence, of course, prevalence of migraine is 100 times higher than of multiple sclerosis. But besides that, the prevalence by age and gender is pretty similar to that one of multiple sclerosis. We see here that in the productive ages from 20 to 40 or even to 55, we have a peak for both females and males. In the case of migraine, of course, females are suffering much more often than males. And this is the case for multiple sclerosis as well. You see here the peak in the same ages for the females and the same ages for males as well. So there is really very similar pattern of the prevalence for both disorders, and the variation by age and gender looks like exactly the same. Those data generate, ideas. If we go to see another very common pattern among the two conditions, depression. We know that in several cases of migraine or of multiple sclerosis patients, the principal condition that causing the highest disability is not multiple sclerosis per se, it's not migraine per se, but it's depression or general anxiety disorder. And here we see that how much often depression or anxiety is comorbid with several types of primary headache disorders. And here is migraine with aura, migraine without aura. Here we have chronic tension type headache, mixed headache. The study is old. And then we have medication overuse headache, which is a migraine variant. It's 35 times more often depression or anxiety versus those that don't suffer from migraine or any kind of headache. The same is in multiple sclerosis. The comorbidity of depression, of anxiety, or even of bipolar disorder is extremely high. And that one raises very important clinical consideration regarding the management condition, because very often we're taking care of the pyramidal signs, of the visual loss, of everything that's related to T2 lesions, and we're leaving aside the real problem of our patient, which is depression or general anxiety. The same for migraine too. So, there are data showing that migraine is more than 3 times more prevalent in patients suffering from multiple sclerosis. When we are approaching to see a comorbidity, there are several methodological issues we have to resolve. According to me, the best one is to perform a longitudinal study, because the cross-sectional studies is just a photograph, a picture of one slide in our lives. The study I have performed, because I also had that question, I had that one for systemic lupus erythematosus, rheumatologists believe that there is a specific type of migraine, headache lupus. So I did all those studies just to prove that there is, I didn't know, and I found out that there is no real comorbidity. And they also believe, as many neurologists believe, that the exaggeration of migraine may be a feature of a migraine, of a multiple sclerosis relapse. This is not true. This is not true. So what we have done is we took three groups of participants. One was multiple sclerosis patients, monoorganic autoimmune disease, systemic lupus erythematosus, polyorganic autoimmune disease, and healthy subjects. So we scanned them very carefully with several scales. We examined them neurologically, everything in very detail, and we follow up them for 1 year with very particular headache diaries to see whatever during the year co-suffering from multiple sclerosis or systemic lupus erythematosus or for nothing is a new development of headache, or if there is an increase in the headache pattern. So I will not show you in details the study results, but believe it or not, we found no correlation between migraine, tension type headache, and multiple sclerosis or systemic lupus erythematosus compared to healthy controls. So you have time, you may go to see that study in headache 2011 to see all the details. But this here is every 3 months the prevalence of migraine in 3 groups: controlled, systemic lupus erythematosus, and multiple sclerosis, according to the everyday headache diaries. What we found is this one, that there was a real difference in multiple sclerosis patients suffering from depression and in migraine sufferers also suffering from depression as well. So what I believe, and this is the data that are proving, is that when you have a patient suffering from migraine and depression, then you have an increase in the headache frequency attack. And the same goes with multiple sclerosis. When the patient is also suffering from migraine and from depression, you do have and you do see an increase in migraine attacks, making the neurologist believe that it's the multiple sclerosis that's causing the migraine attack increase. Is migraine a precursor of multiple sclerosis? If there is indeed an etiopathogenetic correlation, I would believe that. But according to my knowledge, I couldn't find a really very convincing data showing that there is a common etiopathogenetic pathway between two diseases. So to proceed a little bit faster, there are, of course, theories connecting the two conditions. And if you go even to the animal studies, you will see, piece of data proving that in the migraine context, you do have an immune alteration, which is why, because we do have inflammation in the context of migraine. That's why migraine looks like a meningitis. It's an autoimmune response of the dura during the attack. It's everything the same with the meningitis except fever. So we have data, very nice, in animal studies showing that there is an alteration of several biomarkers related to the autoimmune alterations during the migraine attack or even between the attacks. I'm not showing you data, but one very nice piece of work is that one connecting the TNF-alpha alterations during the migraine aura, which is the same during the multiple sclerosis attack, although several studies showing that by targeting TNF-alpha, we don't have a therapeutic effect, but that's happened because TNF-alpha has two receptors, one good and one bad. So if we target to both, then we may have no benefit in terms of therapy. But now there are several studies showing that if we go for TNF beta receptor, we may have benefit in treatment. So another very nice theory is that the propagation of cortical speedic depression during the migraine aura causes several alterations in biomarkers that you may correlate them with any autoimmune response. But again, all those are theories, and if we want to believe that there is indeed a correlation between the two conditions, we may look at the deeper. So, if there is any question, I don't know how I can see it, but let's see here. No, okay. So there is no question so far. Again, the cortical speedic depression is causing several other lesions that may be more often related to ischemic-like pathophysiology than to inflammation. I insist on that one, although there is no proof for any theory in both directions. There are several cases presenting with migraine-like features, and afterwards we discover that we have multiple sclerosis case. So to answer that question, there is no particular study to see what are the trigger factors for migraine or for multiple sclerosis in those particular cases. So according to me, it's just a random co-occurrence. But what we see in our clinical practice is we're seeing a female, a young female, suffering from migraine, sometimes from migraine with aura. We are performing an MRI scan, and then we are seeing those lesions. And then we dance together with our patient to see what is really going in this particular case. Yeah. So let's move now to the most important topic in our conversation, to see what are the principal characteristics of those T2 lesions that are related to migraine or to multiple sclerosis. The other important thing is that when you have a case suffering from both conditions, to recognize that there is indeed in some cases a migraine progression. So by years you have new T2 lesions which are atypical. But when you are counting the new T2 lesions, you are counting everything. Even ischemic lesions, because in patients older than 50 years, there are very many T2 lesions that are ischemic. We are not able to distinguish. So we are counting everything. Typically, multiple sclerosis lesions are very ventricular. Typically, migraine lesions are in the posterior circulation. away from the ventricular system. So let's see how often someone could expect to see T2 lesions in migraine patients. Roughly, I would say that in 1 out of 8 cases, you will see T2 lesions. But those T2 lesions are really away from the ventricular system and located within the posterior circulation. I would say exclusively. So, and I'm going, I will pass those to go to the particular cases to find the, here we are. So, this is a patient suffering from multiple sclerosis. This is a patient suffering from multiple sclerosis too. But the location and the architecture of these T2 lesions are different. We know from McDonald's criteria which one we have to count. But those one, we shouldn't count them regularly in the burden of T2 lesions of multiple sclerosis. So look at this, the location in the juxtacortical multiple sclerosis, those one, those may be, those are not. The posterior ventricular T2 lesions without enhancement, of course, are not identical to multiple sclerosis. But in a patient suffering from multiple sclerosis, we don't have this opportunity to distinguish if a patient suffering from migraine and you are seeing T2 lesions within the posterior, even juxtacortical location, T2 lesions, you may think, or we have to think, that may be related to migraine. And definitely, we don't have to count them as new T2 lesions or provoking us, triggering us to change treatment. Because if we have a patient with increasing T2 burden without relapsing, then we have to really think whether this is the case, we have to change treatment or not. That one is the easy part. If you have within the spinal cord lesions that are in no way to be related to migraine, or if you have gadolinium has, those are the typical ones, lesions, again, those are not related to multiple sclerosis, are not related to migraine. Sorry. Okay. When we have both conditions, which is the most important, we have a patient suffering from migraine and migraine with aura and multiple sclerosis. So the girl comes to us saying she's suffering for a prolonged aura. She cannot speak, she cannot understand, numbness in her arm, and sometimes blurred vision, which is the principal clinical test. Ask her to close the eyes. Does this visual phenomenon persist? Then this is the case of migraine aura. The other important thing is that during a migraine aura, all those visual changes, all those visual disturbances last for maximum of 1 hour. Of course, you may have a prolonged aura, and that's the case that you cannot recognize, you cannot distinguish from stroke one if that happens for the first time. That's why we have many cases of migraine aura that are thrombolized. But those are the criteria. Those are the criteria. It's difficult to me to count a migraine aura as a multiple sclerosis relapse. Of course, there are some cases when you have a left pyramidal syndrome or a left hypestia syndrome that goes and comes front and back. That very often happens in the context of a relapse. But after a few while, you will see a permanent condition. So it's really difficult to be confused between those two conditions. If you have other signs outside brain, there is no way to believe that that one must or could be related to migraine. So if you have symptoms or signs corresponding to any level of the spinal cord, you are away from migraine, and you don't have any reason to be confused or be questioning whether migraine aura could be related to that picture. This table summarizes in a pretty nice way what is related to multiple sclerosis relapse, what is related to migraine aura. Again, only 3 features you may have during a migraine aura. It's visual loss, not loss, visual changes that are dancing in the eye of the patient and persist when the patient closes the eye. And they last maximum 1 hour. Of course, you may have prolonged aura, but that's very, very, very rare. The other one is that you have speech disturbances, very uncommon in multiple sclerosis, unless you have a PML case. And you also have numbness. Again, all those changes last maximum 1 hour. And after that, you have the headache features that secure the diagnosis of migraine aura. Should we put a patient known that is suffering from both conditions in an MRI when we have for first time migraine aura? According to the European Headache Federation guidelines, when you have for first time presentation and development of migraine aura in a patient suffering from migraine without aura, you may put the patient in the migraine. So that's exactly the case for the patients suffering from migraine with aura and multiple sclerosis. In a few months, you will do that one in the other way, just to monitor your treatment in the multiple sclerosis. So there are several cases showing that when you have brainstem lesions, you may have, in the context of multiple sclerosis, migraine-like presentations, but those are very extreme rarely. And personally, I'm practicing in both conditions for more than 20 years, and I really cannot recall any case that I was really confused. But this is not the case. I mean, because several colleagues are asking me to solve any daily problems they are facing, and some of them are related to the co-occurrence of migraine and multiple sclerosis. What do we do in terms of management? We treat both conditions separately. We have to offer we have to offer prophylactic treatment for migraines, in particular when the patient is presenting with more than 1 or maximum 2 days, disabling days per month, just to prevent chronification of migraine. And we do the same for multiple sclerosis, like the patient was not suffering from the other condition. We treat severely the attacks with precise and efficient symptomatic treatment. We have the non-steroidal anti-inflammatory drugs. We have the triptans. We do offer a rescue medication always for a migraine sufferer, just to avoid him or her visiting the ER. And when the prophylactic treatment criteria are fulfilled, and prophylactic treatment. And we do the same for to prevent the progression of multiple sclerosis. So we treat them separately. There are several questions now related to the use of monoclonal antibodies in a patient who is suffering from migraine and for multiple sclerosis. Personally, I have no reason to avoid to offer a monoclonal antibody against CGRP to a patient suffering from multiple sclerosis, even to be treated with monoclonal antibodies targeting all the new even B cells or T cells treatments. So having said that, to me, there is no good data proving that there is a real comorbidity between migraine and multiple sclerosis. But as a clinician, as a physician practicing both fields, I really understand the dilemma we are facing very often. In those patients, they are suffering from both conditions. We have to know pretty nicely and pretty well the characteristics of tissue lesions that are associated to migraine and the other ones that are associated to multiple sclerosis, just to avoid increasing the burden of multiple sclerosis in the patient who also suffers from migraine. What we do in terms of management, we treat both conditions separately as they were individual. So that exactly I have to say, and let's see, there is a question and answer. Okay, so Esra Kamal, is there any neuropediatric webinar? If yes, please tell me. I don't know of neuropediatric webinar with this topic. Is that one you asked me?
No, thank you, Professor Demos. Thank you very much for your presentation, and you illustrated very beautifully the interlink between both migraine and multiple sclerosis. Before leaving the floor to Professor Dr. Oussama Abdelghani, who is the president of the headache chapter of the Egyptian Society, there is a question asking about the prevalence figure of for MS in migraine and the vice versa, the prevalence of migraine in MS patients. Is there any figures for or numbers, I mean?
Is exactly as in non-MS patients, varies from 8 to 18%. In my study, it was less, it was 6%.
Okay.
Okay, it was 6%.
There is another question about, is there any difference?
I can't.
Sorry. Please go. Please. Can you hear me now?
Yeah.
Go on, please.
I was not able to hear your question. Can you repeat it?
Is there any difference regarding the prognosis or management between patients with MRI lesion and those who are without or with migraine?
No. This question has been answered by the camera study performed in Netherlands a couple of years ago, showing that there is a slight progression of T2 lesions in those patients suffering from migraine with aura, but there is no indeed an increase in migraine frequency attack, nor any sign related to the increase in T2 burden with any assessment of the of the memory or of the function. So there is really no data nicely convincing us that there is a progression in the context of migraine. What we do is we treat independently to T2 lesions, patients suffering from migraine. We may offer them earlier a prophylactic treatment, but that's the maximum we can do.
Okay, question from 𝐓𝐢𝐬𝐬𝐻. How are you, 𝐓𝐲? He is one of our colleagues in Libya, and it's had been a long time to hear from him. So he's asking about management of acute migraine in pregnancy. Acute migraine in pregnancy.
What we do, the safer way, there is a very nice review published by the SAS School of the European Headache Federation, just a systematic review of any available data for patients suffering from migraine during pregnancy and lactation. So the safer solution and suggestion is to offer to our patients around 1 or 2 grams of paracetamol or acetaminophen. I don't know how you call it in your countries. If there is a vomiting or nausea, together with metoclopramide, 10 milligrams. That's the safer solution to treat symptomatic migraine attack during pregnancy or lactation.
Okay. Thank you for now, and I think we are going to be with us till the end of this webinar. If there is any more question, I just want to for all attendees to know about the YouTube channel of our society, and the link has been put on the chat bar. This is the YouTube channel of our society, and if there is any question or any you want to follow the videos, you can follow this through the channel. Now it's the turn of Professor Dr. Oussama Abdelghani, the head of headache chapter of our Egyptian society. Please, Dr. Oussama.
Thank you, Dr. Maged. Thank you, Professor Mitsoukostas, for your nice presentation, and welcome to all the attendees. مساء الخير عليكم كلكم. I hope you are all well and enjoying your time during that hard period. وأتمنى لكم كلكم طبعا الصحة ورب البلد كلها إن شاء الله. Let's go into clinical work, into practice, and we are going to present challenging cases by eminent professors and colleagues who are specialized in both headache and multiple sclerosis. So we'll start with Professor Hatem Samir, professor of neurology in Cairo University. حاتم اتفضل.
مساء الخير عليكم جميعا. مساء الخير. مساء الخير دكتور أسامة. انا بعمل بس شير للسلايدز.
تمام.
بسم الله الرحمن الرحيم. I will start with the first case scenario where you will hear from us 4 case scenarios with different patient journeys and different patient presentation. I will start with this patient called Noha. Noha 26 سنة, engaged. She has just started her job as a bank teller. No special habits of medical significance, complaining of frequent severe headache attacks. The headache history were starting by infrequent episodes, 1 to 4 per month of pulsating headaches since she was senior student in her high school, moderate in intensity and rapidly improving by simple analgesics. 2 years ago, she had more frequent attacks, 8 ل 14 monthly, as indicated by her headache calendar. مرة تانية, الهيديك diary is very important to judge حاجات كتيرة جدا في العيان, مش بس صداع, احنا بنعالج الكونتينيوم الامبريلا اوف هيديك. قبل الاتاك بتاعت الهيديك by 1 or 2 days, she always has cranky mood, مش على بعضها, food craving, unexplained fatigue that warn her that migraine is coming. Afterwards, بعد ما بيخلص الميجرين, she frequently has difficulty thinking و fearfulness و blah for as long as a day. ما بتبقاش برضه حاسه انها مبسوطه, قبلها مش على بعضها وبعدها مش مبسوطه وحاسه بخوف شويه ومش مركزه. Infrequently, she reported flashing lights that gradually spread to involve most of the right side of her vision. During those episodes, she had difficulty focusing her vision. About 5 minutes after the visual disturbance, sometimes she had a tingling sensation on the right side of her face and right upper limb. الحقيقة هو ده اللي كان يمكن بيتكلم عليه دكتور ميتسي كوستس about the some episodic and focal neurologic manifestations and symptomatology that associated with the headache or migraine continuum. The visual symptoms resolved approximately within 30 minutes, but she had continued to feel some tingling in her face and mild impairment of coordination. شوية بقى موتو ابتدت تحس بيها ساعات, كل ده ساعات مش دايما, وبتبقى infrequent الحقيقة. في right hand for several hours, تقعد لها حوالي 6-7 ساعات, very mild impairment of coordination في الكتابة, بتظهر قوي في الكتابة. She noticed a mild global headache and light sensitivity whilst her visual symptoms were occurring or after they had finished. This headache gradually increases بقى في الانتنسيتي بتاعتها, ابتدت بتاخد analgesics, كانت بتجيب نتائج. بعد كده يعني ما بقتش الانالجيزكس لوحدها بتبقى كفايه, ابتدت ما تروحش الشغل, ابتدى محتاجه ريست اكتر. زي ما قلت الاورا اللي بتحصل اللي هي visual sensory motor episodes were infrequent and first experienced after taking a hormonal therapy for ACT 4 years ago. يعني هي مع بدايه الكورس بتاع الهرمونال ثيرابي خدته 3 اشهر, مع بدايته ابتدت تحصل لها القصه دي, لدرجه انها وقفت الهرمونال ثيرابي, لكن الابيسودز بقت تكمل وبرضه مش فريكوينت قوي. ريبورتد تريجرز حاجات ليها علاقه بالاكل وسان اكسبوجر, سكيب ميل, ولاك اوف سليب, زي معظم الميجرينر patients. Drug history, she usually received analgesics, zolmitriptan, about 7 to 10 days per month, confined بس للسيفير attacks, ده في الأول خالص, especially during fasting, وفي الاتاكس اللي بيبقى معاها aura with fair response. She did never receive prophylactic treatment. About from 3 months hormonal treatment of acne, negative other treatment history, negative family history, negative history for allergies, and some psychological stresses عندها، وكتير برضه ده بيبقى comorbid مع الميجرين. Symptoms involving nervousness, fatigue, anxiety, and sleep difficulties. System review, vital signs were stable. She's not obese, she's normal weight, body mass index 24. General appearance gloomy, positive for apprehension and anxiety. Head and neck TMJ was normal examination. Neurological examination was normal with bilateral normal fundi and equal reflexes with bilateral flexor-plantar response. By examination, myofascial trigger point كان sternocleidomastoid وanterior temporal muscle والoccipitalis insertion. وده برضه very common trigger points في العيانين اللي بيجي لهم severe migraine. By analysis of her headache الحقيقه هي بيجي لها moderately severe migraine headaches من 8 ل 14 يوم، فاحنا بنتكلم على high frequency migraine with aura وtypical presentation of migraine aura بادئه بفيجوال، بعد كده sensory، بعد كده شويه موتو. ما فيش speech الحقيقه، يعني she didn't complain of any speech difficulty during the episodes preceding or accompanying migraine. عندها برودوما، الكرانكي مود والفود كريفنج، اورا، فيجوال، سنسوري، بلس ماينس موتور لو احنا هنحسبها انها موتور. وبعد كده الهيديك، لايت سنسيتيفيتي، ومعاها فيجيتيتيف سيمبتومز، نوزيا وفوميتنج، وبوست دروم ديسفوريا اند كونسنتريشن difficulties. مهم برضو ان انا ااكد تاني ان الاورا happened following initiation of hormonal therapy. والموست annoying symptom دايما في العيان الميجرين، ايه الموست annoying symptom بالنسبه له؟ هي بالنسبه لها كانت اللايت سنسيتيفيتي والفوتوفوبيا. هي كانت بدات بلو فريكونسي ميجرين وقلبت لهاي فريكونسي ميجرين في اخر سنتين. كان السؤال ليه جيتي دلوقتي؟ which is برضه a very important question تسال العيان بتاع الميجرين. انت بقالك 6-7 سنين، يمكن هي بالنسبه لها 8 سنين تعبانه، اشمعنى جايه دلوقتي؟ كانت كتير قوي هيتقال لك الاجابه previous hasty and disappointing consultations. It's very common answer for such question for chronic migrainous patients. الترانزيانت فوكال نيورولوجيك ديفيسيت بتاعت الاورا الحقيقه خلت الفاميلي فيزيشن بتاعهم يطلب منها EEG which was normal and MRI. الام ار اي ده اللي بينه الام ار اي. عندنا imaging lesions، عندنا white matter hyperintensities، يمكن اكتر كورتيكال فوق على الرايت سايد باينه في البرايتال، ومش باينه قوي انها بيري فنتريكولار، لكن هي بريفرالي لوكيتد شويه بالنسبه ل لو هنفكر في عيان يكون MS او ليها significance. المهم هي قصتها لسه شويه طويله، لانها she was referred to a specialized MS unit for assessment where spinal tap was requested، وهو ده اللي خلاها لا انا هعمل ولا مش هعمل. وكان ايه بقى الوايت ماتر ليجنز اللي عندها ديت؟ هل هي non specific incidental findings او others؟ يمكن ميجرينس انفاركشن، يمكن حاجات ليها علاقه بالفاسكولايتس، ولا ده راديولوجيكالي ايزوليتد سندروم والاثنين مختلفين، ولا هي فعلا عندها MS وفي انفيزيبل ساينز. وده الديبيت اللي دايما هنتكلم عليه. بس the most important is clinical examination. It's very important clinical examination and clinical assessment which should be an extensive assessment. المايجرين اسوسييتد وايت ماتر ليجنز الانتنسيفيكيشن بتاعت الابنورماليتيز بتاعته الحقيقه بتزيد مع الفريكونسي بتاعه الميجرين، وبيبقى فيه significant correlation بين الاورا duration والنمبر اوف نيو وايت ماتر lesion، وممكن تبقى progressive. A study evaluating if cognitive decline could be related للوايت ماتر lesions الحقيقه ما طلعتش conclusive results، لكن في association بينها وبين الفاسكولار insults. Exact etiology of these abnormalities دكتور ميتسي كوستس وضحها. I will not go through it. الdeterminant to go through right track بقى هو السؤال الاولاني: why would the physician request MRI؟ اكيد كان في clinical presentation. One of the most important clinical presentations that the patient do MRI and find incidentally white matter lesion هو الهيدك about 40%. لكن عندنا كمان ممكن عيان يتخبط خبطه يمكن minor trauma ويعمل MRI علشان هو anxious مثلا عايز يطمن على نفسه فيلاقي الوايت ماتر ليجنز. او في ريسيرش كنترول احنا ممكن ناخد عيان نعمل له MRI كريسيرش، او looking for pituitary adenoma لحد عنده هرمونال disturbance. اكيد ده مختلف عن عيان بيجي له sensory symptoms او vertigo او tinnitus. هنا دخلت شويه في specifically neurological manifestations او visual problems او even حتى epilepsy. النقطه الثانيه another important issue: how should MRI be interpreted? The nature of white matter lesions considering the shape, the size, the number and location. The prevalence of non-specific white matter lesion الحقيقه الستادي دي very nice، هي قديمه شويه 2010، لكن هي هنا عملت classification للوايت ماتر الام ار ايز whether احنا normal ولا insignificant abnormalities ولا significant abnormality، وقعدت define كل category. وجابوا over 5 years كان في اكتر من 3500 عيان راحوا للهيدك كلينيك ديت، و 530 هم اللي عملوا الايمجنج. كان في 11 عيان عنده significant abnormality و 46% insignificant abnormality. فقصه ان يبقى معانا significant insignificant white matter lesions عاليه قوي في عيانين عندهم headache، وده بيخلينا طول الوقت لو عيان presenting with migrainous attack I should consider يعني 1000 مره ان انا احط diagnosis of MS before extensive clinical assessment. Incidental white matter lesions are increasingly seen on brain MRI في الكلينيكال براكتس عموما بتاعنا، وحتى العيانين اللي ما عندهمش هيدك. لكن الميتا اناليسيس دي بتقول، الميتا اناليسيس دي ل 20000 عيان تقريبا، ال 20000 نورمال بيبل من 16 ستادي، النون نيوبلاستيك انسيدنتال وايت ماتر فايندينج كانت 2%. فطبعا اعلى في الميجرينر بيشنتس الوايت ماتر ليجنز عن النورمال كنترول. علشان بقى اقول النيتشر بتاعت النون سبيسيفيك وايت ماتر ليجن في الام ار اي I should define it. يعني انا مش اي ليجنز هقول دي ليجنز، انا لازم زي ما قلنا اعتمد على النمبر واللوكيشن وفيها جد انهانسنج ليجنز ولا لا، عامله black holes ولا لا. يعني في a lot of work you have to do before labeling such patient with multiple sclerosis or demyelinating disease, up to انك محتاج يمكن investigations more sophisticated. طيب another issue بقى: هل اي عيان هيبقى عنده white matter lesion هقول ده RIS، يعني عنده headache white matter lesion فهقول ده عنده radiological isolated syndrome؟ الإجابة لأ، لأن في الديفينيشن بتاع ال RIS الحقيقة أنا لازم يفولفل الباركوف كرايتيريا at least 3 out of 4. فعلشان أقول إن ال MRI دوت هيبقى ل RIS مع ميجرين، لازم الليجنز اللي موجوده تكون فيها dissemination in space and time. proposed في ال 2017 revision without symptoms, without clinical symptoms after careful extensive examination. طيب السؤال الثاني could it be migrainous infarction؟ طبعا could it be، بس migrainous infarction ممكن قوي تحصل في البوستيريور سيركيليشن اكتر من الانتيريور سيركيليشن، والسيربيلم بيحصل فيه حوالي خمس الحالات بتاعه الميجرينس انفاركشن، ويبقى فيه هيستوري لبرولونجد اورا، وفي عندي ليجن، والليجن ده اناتوميكالي ريليتد للكلينيكال افكشن. الاكيوت اسكيميك ليجنز يوجوالي بتبقى راوند او اوفل، وبتبقى زي لاكيون، فهي اقل من سنتي. another pathway to follow ده مهم قوي، عيان جاي ب MRI white matter lesions and migraine، ممكن قوي بعد الاكزامينيشن ممكن قوي decide to do MRI cervical عشان افولفيل او اكسكلود في radiological diagnostic criteria للRIS ولا لا، وده هيبريدكت هو ده ايه. الحقيقه عدم وجود السيرفايكال MRI lesions يعني يخليني اميل قوي ناحيه ان احنا يعني مالناش دعوه بالام اس. في نفس الوقت هيفيدني قوي الاناليسيس بتاع الام ار اي وايت ماتر ليجنز اللي موجوده في البرين. specific blood test may be needed for exclusion of other differential diagnoses زي الفاسكولايتس، ممكن تيجي بهيدك واذر neurological and non-neurological manifestations. ممكن الجا لسي اس اف اناليسيس، وان كان الحقيقه ده بيبقى عندنا مشكله، وفي نفس الوقت مش كل عيان هيبقى subjected للسي اس اف just with headache and non-specific white matter lesion. I should consider before requesting CSF analysis. Other tests, visual evoked and comprehensive cognitive assessment, which is very important. العيان ده ممكن يكون جاي بميجرين وعنده cognitive impairment، والcognitive impairment ده معاه non-visible manifestations، والليجنز بتاعته مش بتاعه النون سبيسيفيك، يمكن فيها شويه الكرايتيريا بتاعه الRIS، فهنا I have to consider الحقيقه الكلينيكال بقى، والبرين فوليومتري برضه ممكن يساعدني. وات اباوت نوها؟ الحقيقه هي عملت السي اس اف و it was normal، وكده هي ما بقتش داخله في سكه ام اس خالص. في الفتره دي هي جايه لي وهي عندها 26 سنه بتشتكي 18 سنه، فاحنا بنتكلم على دلوقتي ما ينفعش اقول انها ام اس، ما ينفعش اقول انها هتقلب او مش هتقلب. انا يعني لغايه دلوقتي احنا الدايجنوز بتاعنا ميجرين. الحقيقه she received topiramate and propranolol with satisfactory responses and she performed MRI 2 months later وكان نفس البريفيوس finding. ف الكونكلوجنز الحقيقه ان البرين ليجنز اللي ممكن اشوفها في الام ار اي في الميجرينر بيشنتس are typically small, multiple, hyper intense, punctate like and discrete. ممكن تبقى periventricular، لكن الحقيقه اكتر تبقى peripherally located و no mass effect طبعا. absence of gadolinium enhancing lesions هيخليني اقول ده يعني non-specific white matter lesion. The prevalence varies widely between studies حسب the proper definition of such white matter lesions. Exact etiology remains uncertain, and diagnosis of MS or RIS is unlikely with full migraine presentations. And thank you.
شكرا جزيلا على البرزنتيشن بتاع يا دكتور حاتم للحالة دي، وخلونا بقى نروح في الرحلة الثانية مع زميلنا الأستاذ الدكتور رامز رضا، هيقدم لنا ثاني حالة، أستاذ النيورولوجي، بروفيسور اوف نيورولوجي in عين شمس يونيفرسيتي. One برضك of the pioneers in the work of headache in Egypt. تفضل يا دكتور رامز.
Thank you, Professor Osama. Thank you, Professor Magid, and all the panelists. And I thank the attendees. Professor 𝐍𝐞𝐮𝐫𝐶. It's a pleasure to have you with us. Okay, so I'm also going to present a challenging case where migraine and and MS intersect, and I hope it's going to be a bit challenging for everyone. So allow me to share my screen. Okay, so is that all right? So my name is Ramiz Reda Mustafa. I'm a professor of neurology at 𝐍𝐞𝐮𝐫𝐶 University. These are my disclosures. All right, so what we're discussing is migraine and multiple sclerosis and whether the connection between them is actually a connection or a coincidence. As you've heard from Professor 𝐍𝐞𝐻 that there is a possibility that they're coinciding, and there are also many theories of how they're connected, whether pathophysiologically or epidemiologically. So the patient I'm presenting is, his name I'll put just HSH in short. He's a 34-year-old dentist. He's pretty overworked, but he's very healthy. No previous medical history of note. So his presentation, he came last year in July 2019. He presented to me with a 13-day history of vertigo, which was mainly positional and with slight imbalance. The dizziness and vertigo were not actually very severe, but the patient himself was very anxious. He is a hypochondriac, worried that he's going to have all sorts of medical problems, especially on the first presentation. He was very worried that he has MS. His examination was essentially normal, apart from a bit of hypotension, his blood pressure 90/60, and on neurological examination, some hyperreflexia, which could have been due to his anxiety. Past medical history, on further asking and questioning him, it seemed that he had episodic migraine every now and then, very low frequency, nothing that alarms him. It's typical pulsating headaches that come on either side of the head, sometimes both sides, temporarily, and with some photophobia. Usually relieved very easily with simple analgesics, and he's never taking any preventive treatment or nothing of sort. So for the dizziness and the vertigo, he really insisted that he wanted to do an MRI. So we ordered an MRI in July 2019. So this is the MRI obtained in 2019. Of course, unfortunately, it turned out to have some white matter hyperintensities. So if you see my mouse, there are many of these small dot-like hyperintensities in the centrum semi-ovale. And also there's some periventricular white matter hyperintensities. So not too many, just one here, also periventricular. So these are other slides of the same MRI. And this is the sagittal view. And another sagittal view. So there's one of the lesions here in the centrum semi-ovale that shows up above the corpus callosum. So patient became very worried about these MRI findings and insisted to pursue further tests to prove that he doesn't have MS. I tried to talk him out of it, but he really wanted to do that. So first we did a VEP, a visual evoked potential, and that turned out to be normal. We did more tests like a collagen profile, including ANA rheumatoid factor and antiphospholipid antibodies, and that was again normal. An audiologist did a VNG, a vestibular nystagmography, and that was inconclusive. Also, to exclude ischemic etiology for the white matter lesions, we ordered a genetic thrombophilia screen and protein CNS and antithrombin 3. So really well investigated to exclude that there's a specific etiology for his white matter lesions. So the provisional diagnosis was that he did have episodic migraine. He was clearly very anxious, and that his dizziness or vertigo is probably migraine-related dizziness. Vestibular migraine, migraine-associated vertigo, migrainous vertigo, migraine-related vestibulopathy, they're all synonyms of the same syndrome where you get migraine and dizziness. And the treatment advised was simply 𝐍𝐶, vitamin D, and his audiologist gave him also lucidril, 𝐒𝐞𝐿. So vestibular migraine, just a few slides about it. Vestibular migraine doesn't always cause headaches. Sometimes it's only the dizziness, and sometimes the main symptom and the main presentation is dizziness that comes and goes. Occasionally, patients may complain of also nausea, vomiting, balance problems, as in this patient. And they tend to have motion sensitivity, especially in cars and on trains and boats and things like this. And there are very limited studies showing that vestibular migraine can have radiological findings, just like most migraine patients, where you can have white matter hyperintensities. In this study, 42% had white matter hyperintensities. They differentiated from chronic lacunar infarcts in 14%. So generally about 50% of vestibular migraine patients in this study, at least, seem to have white matter hyperintensities. Generally, white matter hyperintensities have a prevalence of about 50% in the population in their 40s and increases to 90% in people aged 64 to 74. Younger people in their 20s very infrequently exhibit white matter hyperintensities. Basically, they can be classified into periventricular white matter hyperintensities. These are the ones surrounding the ventricles, usually in a cap type. And these are strongly associated with age, hypertension, cognitive decline. And they're thought to be mainly ischemic. The other type, if we can classify in this way, would be the ones located in the centrum semi-oval and the deep white matter and the juxtacortical white matter. And it seems that migraine is more associated with these deep white matter hyperintensities rather than the periventricular. Or you can also in some patients find mixed white matter hyperintensities of the both types. In migraine, there have been many studies to show that the white matter hyperintensities are common. Studies have ranged between 12 and 47% of migraine patients having white matter lesions. And it's been reported for a long time. So this in 2004 up to 2019. And as you can see, some are periventricular, many are in the deep white matter in the centrum semi-oval. And in recent studies where with 3T MRI and new segmentation methods, this figure can go even higher, up to 70% of migraine patients having the white matter hyperintensities. And of course, as you all know, it has to be differentiated from a large number of diseases. One of them is multiple sclerosis, but you can also be confused with lacunes, deep watershed infarcts, antiphospholipid syndrome, and many others. So at this point, I was comfortable with the diagnosis of migraine-related dizziness or non-specific dizziness, and that these white matter hyperintensities were of migraine. So there was a poll that the organizer wanted to put at this point for you to answer. What do you think the right diagnosis for this case is? Based on this information alone, the MRI and the clinical information. So this is a poll for you to answer. For everyone, for the attendees and for the panelists. Okay, the organizers just tell me when to stop the poll and restart the discussion. Okay, so we have the results. Only 3% think it's MS. Some, about quarter, think it's both, but most people would diagnose it as migraine. Okay. Right, so he disappeared, and then in January 2020, he reappeared again, this time with a completely different presentation. Left-sided visual loss, very acute, fogginess in the left eye, faded colors, pain on moving his eye, and a very severe headache. So the headache was unusually severe, not the type he was getting before, not the bilateral temporal moderate headaches that he was getting before, but rather a very severe headache on the vertex, which was persistent most of the day, partially relieved by analgesics, and he would ask his family members to press hard on his head to get relief. And this time, there was very little dizziness. So it's a very different presentation than the first one. So at that point, the differential diagnosis became a bit different. Either this is a complicated migraine, his migraine got worse for some reason, could be an anterior ischemic optic neuropathy, a vascular event like sinus thrombosis, or an increase in intracranial tension, or simply optic neuritis. He had already went to ophthalmology, and we ordered immediately labs and VEP. So surprisingly, the VEP turned out to have very significant demyelination with a P100 latency of 160. The ophthalmology was normal, his ESR was normal. So without delay, he was started on pulse steroids for a diagnosis of optic neuritis. And MRI was ordered and lumbar puncture. So this was the new MRI. So as you would see, his MRI now shows more lesions, such as this one highlighted in this image, in the centrum semi-ovale. This was not in the previous MRI. It seemed also that the number of white matter lesions had increased between July and January. And again, this is his MRI, just a different picture. You can see that the white matter lesions have now increased in number significantly. So on the steroids, his left eye improved quickly. There was still some on and off blurring with eating and with showers. And later he started to feel that his right eye has become blurry too. And he was very anxious and asked to repeat the VEP and repeat the MRI. So the repeat VEP showed that the right side is normal, but the left side had improved with the steroids. And this was the MRI just 2 months later. So the first one was in March, this was in May. And again, only 2 months apart, this one, maybe it's not very clear, but the number of T2 lesions have increased. Here on FLAIR, you can see some new lesions. Also, this one was more geared towards MS to show MS type lesions. As you can see, there are now more perpendicular lesions to the corpus callosum. And the cervical MRI for the first time showed a small but very clear lesion in the cervical spinal cord. The CSF later came back and it turned out oligoclonal bands positive, high IgE index, and thus the diagnosis was completely changed to relapsing remitting MS with episodic migraine, and the patient was started on fingolimod. So this is a very challenging case that progressed from episodic migraine, very simple episodic migraine, to an defined presentation of dizziness, and then later to a presentation with an MS picture, optic neuritis, MS, consistent with MS, and severe headache at the same time. The headache also resolved at the time. I think it raises many of the points that Professor Mitsoukostas was mentioning about the co-occurrence of symptoms and whether they're related or not. And of course, it's open for discussion. Thank you very much.
شكرا جزيلا يا دكتور رامز. Very challenging case. حظك وحش. اللي بيخاف من العفريت بيطلع له. هو كان خايف من العفريت فطلع له العفريت.
العيان كان متأكد انه عنده MS from day one. سبحان الله. العفريت
بيطلع له. فاحنا بقى عايزين الدكتور دينا تصرف لنا العفريت بتاع دي. ونسمع الدكتورة دينا زمزم. One of the eminent professors working in the field of the MS, Professor Dina Zamzam, Professor of Neurology in Ain Shams University. اتفضلي يا دكتورة دينا.
Thank you very much طبعا أستاذي الدكتور أسامة عبد الغني على التقدمة ديت، وأنا أتشرف طبعا إن أنا واحدة من تلامذة حضرتك عين شمس. الحقيقة يعني النهاردة هنتكلم على كلينيكال كيس فعلا. يعني انتوا عارفين أنا بحب دايما أجيب كيسز أو لايف كيسز من الMSQ. ده ميل بيشنت هاني عنده 16. ألو؟ أبتدي ولا إيه يا دكتور؟ male patient 16 years old عنده normal developmental milestones, no fits, no head trauma of neurological importance, with positive family history of autoimmune disease in his cousin, كان عنده rheumatoid arthritis, و positive family history of migraine in his mother, وكان في negative consanguinity. الحقيقة الكلينيكال هيستوري ابتدى معاه من جون 2019. كان trauma during playing football, lower back pain radiating to both lower limbs. والpatient sought medical advice عند neurosurgeon و asked for MRI and CT first and then followed by MRI, and it seems he had a fracture at L4 and L5, and that caused the low back pain and the positive sciatic symptoms. وكان treated non-surgical were just dressed ويعني physiotherapy later on. In September 2019, patient had experienced migraine attacks, photophobia, phonophobia, improves by NICE twice or 3 times per month. The patient يعني didn't seek medical advice. In January 2020, he experienced right trigeminal pain with one of the headaches that persisted after the headache even for 48 hours and improved with and he sought medical advice and MRI brain was requested. Neurological examination at that time was not done في MS unit, لكن كان reported by the parents إن كان في paresthesia in lower limbs which was similar للي كانت موجودة during the fracture. The treating physician at that time has proceeded with CSF, MRI brain and cervical and dorsal spines, VEP, long-term EEG and collagen battery. MRI الحقيقة بينت lesions كانت confluent و periventricular و 3 demyelinating patches، لكن السيرفايكال كان free. VEP كان normal، long term EEG والcollagen battery showed no abnormality detected. CSF showed high IgG index and 2 positive oligoclonal bands. وهنيجي عند أول question, what will be your diagnosis? Is this RIS, just migraine with radiologically isolated syndrome? Is it a clinically isolated syndrome or migraine type or migraine MS or migraine associated with MS? So the floor is open for the poll question. انتوا شايفين عيان بالsymptoms دي بعد الاكزامينيشن او الهيستوري ده والفايندنجز ديت يتشخص على انه radiologically isolated syndrome ولا clinically isolated syndrome ولا الميجرين MS subtype يعني اللي هو في ميجرين وفي MS associated. (15% said that it was radiologically isolated syndrome. 18% showed that, in their opinion, clinically isolated syndrome, and 67% said that it was migraine MS subtype. خلينا نشوف الكيس proceeded ازاي. طيب. Would you treat him as an MS or treat him as migraine or both؟ هتعالج على انه MS ولا هتعالج على انه ميجرين؟ شايف ان مين فيهم فيه المشكلة دلوقتي؟ Would you start treating him as MS or treat him as migraine? Uh, 64% will treat as MS and 36% will treat as migraine. Could migraine lead to MS or MS lead to migraine? Multiple sclerosis and migraine share a lot than the first letter of their names. الشار بينهم إن في various similarities between migraine and MS increase the likelihood of misdiagnosis. زي ما السينيور بروفيسورز قالوا قبل كده، الاثنين are chronic and inhale attacks and remission، فيهم relapses and remission. Both are associated with changes in the brain structure and white matter abnormalities that may be subclinical. يعني لما نعمل MRI نشوفها. Does migraine cause MS؟ يعني ممكن هو لو migrainous patient يجيله MS incidence. الحقيقة في studies اتعملت في 2012 𝐍𝐞𝐮 and colleagues found in a significant increase in absolute risk of developing MS, especially among women with migraine. لو فضل الميجرين ده above 15 years، وده كان compared للwomen without migraine. برضو الميجرين بيزود البرميابيليتي بتاعت البلاد برين بارير والبرو انفلاماتوري سيتوكاينز، فممكن ده يزود الانسيدنس شويه بتاعت الام اس عند البيشنتس دول. العكس ممكن يحصل. هل الام اس can cause migraine؟ Having a history of MS can be associated with a 47% increase in risk of developing migraine. 15% of MS patients reported a frequency of 15 days or more, moderate intensity of headaches per month, كان ده prior relapses. والفريكونسي بتزيد زي ما قلنا before ال MS attacks. يعني ممكن الناس يجي لها ميجرين قبل ال MS attack، وأوريدي البيشنتس اللي عندهم MS عندهم incidence أعلى من الجنرال population إن يجي لهم ميجرين. الأوبتيك نيورايتس ساعات كتيرة البين بتاعه سواء ocular أو ريترو ocular أو بيري أوربيتال أو فرونتال هيدك ممكن يحصل معاه ويبقى ميستيكن إن ده ميجرين. يعني العيان يبتدي يحس بالبين وبالهيدك الأول، وبعديها بيوم أو اتنين يبتدي البلورينج أوف فيجن، وفي الأول إن إحنا نفتكره على إنه هيدك. البيري أكويدكتال جراي ماتر MS بليك دي an area of gray matter found in midbrain can cause migraine. يعني ممكن العكس، السايت اوف ليجن نفسه ممكن ان يبقى associated بسيمتومز similar للميجرين او الهيدك، او يبقى associated مع الميجرين ويبقى mistaken ان ده ما بين انها MS relapse وما بين انها migrainous attacks. في الميجرين MS subtype ان البيشنتس اللي عندهم MS وعندهم ميجرين يعني comorbidity were younger in age with a shorter duration of disease, more severe course, rather progressive than relapsing. الأنست بتاع الميجرين نفسه may trigger inflammation in the brain and may result in increased number of T2 lesions and T1 enhanced lesion. Altered brain perception في الميجرين بيؤدي إلى escalation للreported symptoms of pain and non-pain related. يعني إيه؟ يعني الناس اللي عندها ميجرين وعندها MS ممكن تبقى أصغر في السن، ممكن الكورس بتاعها يبقى بروجريسيف أكتر، ممكن يبقى مور سيفير، ممكن نلاقي الليجن لود اعلى شويه سواء T2 ليجنز او انهانسد ليجن. والاهم ان العيانين دول الكواليتي اوف لايف بتاعتهم ممكن تبقى اسوأ، لان البين بيرسبشن عندهم بيبقى مختلف، فممكن reported symptoms او self report symptoms منهم سواء دي related للبين او not related للبين تبقى ازود او اكتر. في عندنا مشكله ثانيه، العيان ممكن ما يبقى من دول، ممكن يبقى radiologically isolated syndrome، يعني ما يبقاش MS ولا MS subtype migraine، ممكن يبقى radiologically isolated syndrome اللي هو احنا لاي سبب من الاسباب بتاع في النيورولوجي قررنا ان احنا نعمل MRI للبيشنت، نلاقي oval well circumscribed and homogeneous foci، ممكن تبقى involving الcorpus callosum or not، الميجرمنت بتاعها يبقى اكتر من 3 مللي and fulfilling Birkhoff criteria 3 out of 4 في dissemination space. CNS white matter anomalies is not consistent لو كانت vascular، وما يبقاش فيه history ل relapsing remitting course disease من neurological dysfunction، وما فيش impairment في السوشيال او الاوكيوبيشنال او الجنرالايزد اريا اللي ليها علاقه بالفانكشن related للسايت اوف ليجنز دي، يعني ما يبقاش عنده مشكله مثلا في برين ستيم في حاجه وعامله له مشكله في المشي او الحركه او ايا كان في سيمتوم دل عليها عامل له مشكله سوشيال او اوكيوبيشنال، وما تبقاش due to drug abuse او toxic exposure. فده مهم جدا، ولازم برضو نستبعد الفاسكولار ريسك فاكتورز زي اليوكو اريوزز او الاكستنسيف وايت ماتر باثولوجي. يبقى ده ممكن برضو يبقى بدايه radiologically isolated syndrome. نرجع لهاني اللي هو احنا شخصناه على ان هو MS، وقلنا ان احنا هنبتدي بنسبه او نسبه عاليه منكم قالت انه هياخد التريتمنت بتاع MS. الحقيقه البيشنت كان prescribed interferon beta 1A 30 مايكروجرام intramuscular once weekly. However, البيشنت بعد الانجكشنز كان experience fever, psychotic behavior lasting for 1 or days، والفريكونسي بتاعت الميجرينس اتاكس زادت. البيرنتس عملوا ايه؟ البيرنتس خدوا راي another medical advice او راحوا لسينيور بروفيسور تاني اللي نصحهم ان هم يوقفوا التريتمنت بتاعت الانتراماسكولار انجكشن بتاعت الانترفيرون to stop it immediately، وقال ان ده side effects او symptoms دي side effects منها. والحقيقه حصل improvement للفريكونسي والسيفيريتي للميجرينس اتاكس بعد ما وقفها، والسايكوتيك فيتشرز اللي كانت بتيجي يوم او اتنين ريليتد للانجكشن راحت، وما كانش فيه نيورولوجيكال ديفيسيت. لكن كانت المشكله عند البيرنتس هو الهاجس بتاع ان ده patient with MS and he is not treated، وده عنده 16 سنه وما خدش علاج، وخايفين طبعا انه يبقى crippled او handicapped او disabled لو سابوه. ده الهيستوري بتاع العيان زي ما قلنا لحد January 2020 اللي كان فيها التراجيمينال انسيدنس ديت، واللي اتشخص على اساسها على ان هو MS positive CSF and oligoclonal bands و MRI lesions. الحقيقه هو العيان جاء seeking another medical advice وجاء MS unit، واحنا عملنا ساعتها another MRI لقينا stationary، والEDSS assessment كان عندنا في MS unit 0، يعني احنا ما لقيناش اي دليل على ان في neurological deficit وقت ما شفنا البيشنت بعد ما كان موقف التريتمنت. السؤال اللي بعد كده، احنا دلوقتي لما جالنا في MS unit nowadays، يعني ده الكلام ده كان في شهر 5 او النص الثاني من 5، would you consider treatment of this patient as an MS؟ يعني المفروض نوصف له treatment تاني، treat him as migraine or just treat symptoms. الفريكونسي بقت بتاعت الميجرين ما تزيدش عن 1 أو 2 يوم، يعني آخر شهر أو 2 اللي كان فيهم، وهم mainly كانوا جايين seeking الميديكال advice عشان التريتمنت بتاع MS. لكن هل إحنا هنكمل تشخيصه على إنه ميجرين، ولا هننسيست دلوقتي بعد ما عملنا له assessment إن إحنا نعالجه على إنه MS، ولا هندي symptomatic treatment بس on demand بالنسبة للسيمتومز اللي بتيجي أو الميجرينس اتاكس أو الهيدك الموجود؟ نشوف النتيجة. الحقيقة واضح إن الناس غيرت رأيها. يعني بعد ما كان حاجة و60% هيعالج إنه MS، 36% بس قرروا إن هم يعالجوه كأنه MS، 21% قرروا إن هم يعالجوه على إنه ميجرين ببروفيلاكتيك تريتمنت، و43% قالوا هيعالجوا السيمتومز. طيب if you decide to treat, what will you prescribe؟ هترجعوا لنوع تاني من الانترفيرونز غير الافونكس، يعني عشان نقول بالاسم النون ميديكال، بس خلينا نقول انه الانتراماسكولار انجكشن 30 مايكروجرام once weekly. هتديله فنجوليمود على اساس ده برضه licensed for pediatric. هتدي الارينوماب كبروفيلاكتيك ثيرابي بالنسبه للميجرين. هتدي ستيرويدز على اساس ان ده لو ميجرينس اتاكس دلوقتي، او ده كانت اتاك من MS وتعالجه، او none of the above. مش هتدي تريتمنت دلوقتي، وهتشوف بس العيان على اساس ان هو جاي لك بMRI فيتشرز فعلا اوليجوكلونال بانس، بس انت وقت ما شفته وانت مش لاقي نيورولوجيكال ديفيسيت والMRI ستيشنري. لكن هل هتبروسيد على انه MS وتدي disease modifying treatment؟ هتبروسيد لبروفيلاكتيك تريتمنت زي ما انتوا قلتوا بالنسبه للميجرين. هدي ستيرويدز دلوقتي لان لسه شايفه، هدي ستيرويدز في MS يونت على اساس ان انا لسه شايفه وخايف يكون في اكتيفيتي، او none of the above. وخلينا نقول مش عشان دي طبعا نوفارتس يبقى لازم ندي الفنجوليمود. اوكي، يعني معظم الناس قالت none of the above، ان هي هتدي زي symptomatic treatment. percent قال هيدي steroids 16%، قال انه هيدي التريتمنت بتاع الكورونيك ميجرين الارينوماب. الفنجوليمود 22%، والانترفيرونز لان واحد منهم جه سايد افكت عليه، ف 4% بس اللي شافوا ان هو ممكن نكمل عليه. كان ايه راينا في الكيس دي؟ عملنا assessment. الحقيقة patient was diagnosed as radiologically isolated syndrome. No typical symptoms of CNS demyelination. كان كلها باراسيزيا، وغالبا كانت من lumbar fracture زي ما بيقولوا، بتروح وتيجي مع الفتيج ومع الإرهاق. No formally accepted diagnostic criteria عنده. CSF abnormalities واردة حتى في radiologically isolated syndrome. لكن في الفيوتشر ممكن يحصل clinical MS attack توصل ل 35% من البيشنتس دول over 5 years. ممكن يحصل MRI progression في البيشنتس دول up to من 60 ل 83% within 2 years. وممكن ساعتها نشوف disease modifying therapy to be initiated. احنا وقفنا كل DMDs لان احنا لقينا لما بنرجع للليترشر ان الديزيز موديفاينج تريتمنتس نفسها ممكن تكون سبب في زياده الفريكونسي بتاعت الميجرين. الانترفيرون ريبورتد الحقيقه ان ممكن يحصل up to 40% للبيشنتس بالذات مع بدايه الاستخدام ميجرين. التاريفلوناميد بيحصل 16% منه ممكن يحصل معاه ميجرين، والفونجوليمود 13%. طبعا الابروفد في البيدياتريك ايج according to 𝐓𝐷A mainly هو الفونجوليمود ويمكن الانترفيرونس، والاثنين زي ما احنا شايفين ممكن يزودوا الفريكونسي بتاعت الميجرين في radiologically isolated syndrome. يعني هو لسه ما وصلش لمرحله انه يبقى clinically isolated او حتى relapsing remitting MS. هندي symptomatic treatment طالما ان الفريكونسي بتاعت الميجرين قلت قوي up to 1 day او 2 days بعد ما وقف التريتمنتس كلها بتاعتنا. هنأسس clinically every 3 months لأن احنا زي ما قلنا ممكن نسبة منهم في خلال ال5 سنين تقلب إن هي up to 50% ممكن إن هو يجيله attacks أو clinical attacks. هنعمل MRI كل 6 شهور لأن احنا لقينا من 60 ل 80% ممكن يحصل new lesions. ولو حصل أي MRI changes أو clinical defect هنconsider him as an MS and treat the patient. لكن now leave the patient alone من غير أي side effects, just follow up. Finally, the correct diagnosis is 3/4 the remedy. Thank you very much.
شكرا جزيلا يا دكتورة دينا على الحالة الانترستنج دي، وهي تشالنجينج فعلا لأن أخذ قرار فيها صعب، واعتقد ان اتس فيري وايز فعلا زي ما انت قلتي ان احنا نتابع المريض، وخصوصا ان هو عنده الاولوكلينال بانس بوزيتيف والاي جي اندكس كان عالي. شكل الليجنز برضك يعني كبير شويه وكونفلونت. هل ده كان عنده حاجه اكيوت ولا حاجه بالصدفه، ولا التراجيم النيورالجيا دي كانت جزء من افكشن ولا من ميجرين، ولا يعني اتس فيري كونفيوزنج يعني. Thank you very much for the presentation and for the case. نورتينا يا دينا. خير الختام بقى بالنسبه للدكتور عمرو حسن، استاذ مساعد الامراض العصبيه في جامعه في كليه طب القصر العيني. بروفيسور دكتور عمرو حسن هيقدم لنا اخر حاله وختامه مسك ان شاء الله يا عمرو. اتفضل يا عمرو.
السلام عليكم جميعا. Thank you Dr. أسامة for the very nice and very kind introduction. الحقيقة it's my pleasure to be a speaker with you today. الحقيقة الميتنج is very unique and very different. يعني مختلف عن كل الميتنجز اللي احنا ممكن بنكون بنعملها قبل كده، لأنه بيجمع ما بين two branches من النيورولوجي which are the very hot topic nowadays in neurological disorders in general. So now I will start the case presentation. This is my disclosure. I would like at the start to thank Novartis actually. الحقيقة إنها فكرت في الفكرة إن إحنا نكونكت الMS للمايجرين، لأن الحقيقة يعني كبرين ستورمينج وايز we had very nice يعني thoughts about the connection, and I think we now are more aware with the connection after the presentation of Professor Demos and the cases presented with by my colleagues. So now I will start the case with the history. She's a nice lady, Nisma. She's housewife, 31 years old, and she had uneventful past medical history since early childhood, but with repeated attacks of headache. This headache was bilateral and associated with vomiting, sometimes vomiting without headache, and recurrent numbness. This history while she was a child. So the history is a bit defective because she was just trying to retrieve the history from the very early childhood. She was on no prophylactic treatment due to the very low frequency, so her treating physician while she was a child was reluctant to put a prophylactic treatment due to the low frequency of headache. However, 2 months ago, just before I saw her, the frequency and duration and severity of the headache attacks increased remarkably, with severe dizziness mounting into vertigo in some days, with blurring of vision and hurting scalp. When I examined her, she had entirely normal neurological examination, normal mental status, speech, language, no limitation of ocular motility, even no nystagmus, no facial asymmetry or facial sensory abnormality, no weakness, no change in deep tendon reflexes, no superficial or deep sensory loss, and gait and coordination were also normal. So the first question, based on this history, would you ask for brain imaging? Yes, no, or not sure? الحقيقة ما بحبش اختيار نوت شور ده، بس يعني حطيته كده عشان يبقوا 3 اختيارات يعني. وبرضه نوت شور ده بيناسب الناس اللي هم الناس بتوع ليبرا والجيميناي، الناس بتوع الجوزاء والميزان. الاختيار ده كده بيغسلهم من جوه كده، بيحس ان هم مطمنين لوجود نوت شور. So please vote yes, no, not sure. Would you go for brain imaging or not? Patients with migraine just becoming with worsening of migraine and increased dizziness and blurring of vision. Would you proceed or not? Please vote.
فين الفوتنج سيستم؟ الاورجنايزرز. ايوه.
Yes. Dr. Hatem had presented a slide on when to do an MRI for patients with migraine. It was a very nice slide. It split it into with and against. And 90%, thank you, 90% voted for yes, do imaging. And this is exactly what I've done. I proceeded into the brain imaging, and we found here these very tiny lesions distributed bilaterally, cortical and subcortical, which is very matching with the diagnosis of migraine. The patient was diagnosed with migraine, and this is very matching. However, when we look to the brainstem, we found here we found this lesion. Look here, there is a cerebellopontine lesion here, and we have here another temporal cortical lesion. So based on these data, and after having these lesions, which are some of them are typical or maybe suggestive of migraine, but others are not, based on these data, what would you ask for next? MRI cervical spine, lumbar puncture for oligoclonal bands, anti-aquaporin 4 antibodies, autoantibodies to exclude vasculitic disease, pathology test, CSF cytology, anti-cardiolipin antibodies, lupus anticoagulant, or anti-beta-2-glycoprotein, taking into consideration that your choice will reflect what do you think about in this case. So these choices are reflecting the differential diagnosis I thought about, and it will reflect consequently the choice you are thinking about. So please vote. معكم 30 ثانية من ساعة ما بيظهر البتاع ده على الشاشة. And the results, 37% voted for MRI cervical spine, 20% for lumbar puncture, 13 anti-aquaporin, and no one voted for antiphospholipids, or just 2% for pathology, 8% for CSF cytology, autoantibodies, 21%. Okay. So I went with the choice of the majority of you. I think that MRI cervical here is very important. The slide is freezing. So the differential diagnosis here is NMO or MS. That's why I've chosen to do MRI cervical, just to exclude NMO or multiple sclerosis. Here, oligoclonal band, the same differential diagnosis. NMO, here vasculitis, pathology test for VESIT, CNS lymphoma, and here antiphospholipid syndrome. But we forgot that I want to highlight this part, because are we sure that this patient had migraine? Because in order to put the migraine as a keyword in the diagnosis or the differential diagnosis, we have to make sure that this patient has migraine. So here the migraine history of this patient has some red flags. the bilaterality, and the vomiting that might occur without headache. So if we revise the criteria of pediatric migraine, we will find that criteria of pediatric migraine is nearly looking like that of the adult. However, the duration might be briefer, just 2 hours instead of 4 in case of adult. Another thing, the bilaterality here. The bilaterality in pediatric migraine is the rule, and the exception to be unilateral, on the reverse of the adult. In adult, it's unilateral with the exception of being bilateral. Here is the reverse. So in this patient with bilateral pulsating headache, it is migraine. And another thing, the vestibular migraine. Vestibular migraine might present with dizziness and vomiting that happens once past in the patient history of vomiting without migraine in many cases. And the vestibular symptoms, in order to be diagnosed as vestibular migraine, might last only for 5 minutes, just 5 minutes, and it should be counted as vestibular migraine. So if we try to connect the two conditions we are suspecting, migraine and MS, interestingly, I found this case report of a patient with MS presenting initially like our patient with worsening of the migraine symptoms. Just worsening of migraine symptoms is the initial presentation. Another differential diagnosis, which is NMO. Someone might ask, what would you think about NMO as a differential diagnosis? Here is the most important thing in the patient history is the vomiting. The patient had recurrent attacks of vomiting without headache, and vomiting is very important in patients with NMO. As we see here, the area postrema syndrome might present with nausea, hiccup, and vomiting. So unexplained vomiting in such patient might be explained by the NMO or vestibular migraine. So we should here go for MRI cervical in order to, we might find a long extensive transverse myelitis. Another thing here, that NMO might present with brainstem lesions like our patient. But look here, for these lesions characteristic for NMO, it is mainly periependymal here. It's periependymal lesions, like here. It's just following the water channels. That's why it's distributed like this. This is the lesion of our patient. It was just marginal in the cerebellopontine angle, and this lesion بالنسبة لي أنا it looks like this child after drinking a sip of milk. تقريبا نفس الشبه كده، اللي هو تحس إنها لحوسة حوالين الفورث ventricle. This is typical for NMO. If we think about Behçet, despite just 2% of you voted for Behçet disease, however, in Behçet disease, the headache is a very common feature. But to be honest, the tension type headache is the most important type of headache in patients with Behçet disease. And we all know that Behçet disease might present with lesions in the brainstem on the posterior fossa. But if we look here to the lesions in the brainstem, it is mainly central, mid-pontine, and central, and large, not like the lesion of our patient, which is eccentric and to the cerebellopontine angle. And this is because the lesion here is ischemic, and the ischemia in the brainstem tends to be central, general ischemia. And of course, here we don't have the most important criteria for diagnosis of neurobehçet, which is the orogenital ulcers. None of you thought about the APS. I don't know why. The antiphospholipid syndrome. The antiphospholipid syndrome might present with migraine, but you are right. You are right, because the major criteria and major clinical criteria should include in APS the vascular thrombosis and the pregnancy morbidity, which is not the case in our patient. However, I went for the lab criteria in order to exclude APS. Surprisingly and interestingly, migraineurs might have high prevalence of antiphospholipid antibodies. Be careful. Migraineurs might have antiphospholipid antibodies despite they don't have antiphospholipid syndrome. Some arguments are raising about the importance of including the migraine headache into the future classification criteria of antiphospholipid syndrome being of high prevalence among this group of patients. So back to our differential diagnosis. I went for MRI cervical, and the MRI cervical is normal, completely normal. And I did all the lab tests you can imagine. ANA was weakly positive. It's positive, but it's not of high titer. ANCA, anti-smooth muscle, anti-DNA, anti-Rho, anti-La for Sjögren's syndrome, negative. Anti-cardiolipin, lupus anticoagulant, negative. Anti-aquaporin 4, negative. Oligoclonal bands, negative. IgG index is not high. So I went back to the migraine history of the patient, and I revised the brainstem lesion and went to the literature back to see the type of brainstem and cerebellar lesions in migraine patients. And I found that brainstem and cerebellar lesions are common, as Dr. Hatem have mentioned, that 21% of the migraine infarctions might occur in the cerebellum and in the posterior circulation mainly, being we all know that the migraine is spread from behind into the front, so the posterior circulation might be the victim for ischemic vascular event of migraine. But again, I found that the brainstem lesions are mainly central and not eccentric, not marginal, not periventricular, as the case in our patients. So again, we might find cerebellar lesions, but here in our patient, we found a cerebellopontine lesion, which is not typical for this pattern of lesions. So based on these data, what would you ask for next? هنعمل ايه بعد كده؟ I want commence DMT. مش هبدأ علاج now, and I'll do follow-up MRI. This is not a case of frank MS, and I would go for MRI brain after a while, or I'll repeat the lab after a while, or I will repeat the MRI cervical after a while, or no. This lesion is very typical for MS, and the patient presented with vertigo, and I will start DMT immediately, despite the absence of oligoclonal bands, which might be absent in very low percentage of cases. And some of you might see this case as a case of migraine. فكك من كل الكلام اللي بتقوله ده. This is a case of migraine, and just give prophylactic treatment of migraine, and this would be enough. معكم 30 ثانية من ساعة ما الكلام ده ظهر. Okay, so follow-up MRI, almost half of you agreed on doing follow-up MRI brain. None of you will do MRI cervical. It's not a case of NMO from your point of view. And 33% are فكك من ده كله. With فكك من ده كله ده حالة مايجرين بلدي. ده تلتكم. اوكي. دايما بيعلق لما ننقل من سلايد الفوتنج. Okay. According to your choice, we will proceed now for the treatment options. What are the treatment options you are thinking about if you choose to treat this patient, whether as an MS patient or MS with migraine or just pure migraine. The treatment here. The treatment here is about the immunomodulation or immunosuppression. Would you go for interferon, teriflunomide, DMF, fingromod, azathioprine, rituximab, others? And as regard migraine, would you go for topiramate? The patient is housewife, valproate, she has 2 children, beta blocker, amitriptyline, botulinum toxin, eronumab, or others. So the next question would be about the prophylaxis of migraine in such case. What would you select for the 33% اللي شافوا ان فكك من ده كله and this is a case of migraine? What would you go for as prophylactic treatment in this case? Topiramate, valproate, beta blocker, amitriptyline, botulinum toxin, eronumab, or else treatment. مش عارف else treatment ممكن يبقى ايه من وجهة نظركم، بس يعني ممكن الناس تختارها كده كنوع من انواع الغموض يعني. I can expect that most of you will vote for topiramate, maybe. We'll see now. Yes, I'm right. Yes. This is around 40% voted for topiramate, and congratulations for Novartis. 20% has voted for eronumab, and 20% for amitriptyline. else treatment ال 2% اتبعوا مبدأ الغموض، اللي هو انا عندي حاجه ما حدش يتخيلها، انا ما حدش يتوقعني. اوكي. نيكست. خلينا بقى ايه طبعا قدامنا كده شويه نتسلى شويه عقبال ما نيكست تيجي، and عشان to be prepared for the next question. The next question would be about the prophylactic treatments if you consider this case is a case of demyelination or a case of autoimmune disease, and what would you go for interferon, for teriflunomide, for DMF, for fingromod, for azathioprine, for rituximab, وelse treatment عشان ال 2% الغامضين ما يزعلوش. Now the results, I can expect that interferon, yes, 37% went for interferon, yes, and again 21% for fingromod, 17% for azathioprine. I think the group who had chosen azathioprine, they are thinking about the condition is looks like an autoimmune, but we are not sure whether it is an MS or something like NMO or something else. That's why azathioprine will be a joker that can play in all fields. This is a nice idea. Okay, this was my last question, and now I will show you what I have done in this case, and we should wait for a few seconds for this slide to recover. بيتشرب كده الصدمه شكله، ما اعرفش ايه، بياخد وقت عقبال ما بينقل. I don't know why. Now you are waiting for the decision I have taken. You are now waiting for the decision I have taken. Suspense رهيب جدا يعني. Suspense رهيب، بس أنا زهقت نفسي من السسبنس. Okay, I can tell you that I've taken the decision to no treatment to be given, just treatment for migraine, and to do follow-up MRI brain and follow-up MRI cervical. After a while, I'm still worried about the NMO despite everything, but the history of vomiting is still flashing in my mind. So I will do her follow-up MRI brain and MRI cervical spine after a while, and according to the results of these imaging, I might go for anti-aquaporin 4 and oligoclonal bands. Interestingly, we went through the journey of finding a connection between the MS and migraine. We found that there are many connections between MS and migraine, but before trying to find always a connection, please mind the gap. Still, there is a gap. Thank you so much.
شكرا جزيلا دكتور عمرو على البرزنتيشن الجميل بتاعك. احنا استمتعنا الواقع بالبرزنتيشنز كلها اللي احنا سمعناها النهارده. اعتقد ان الرحله الكلينيكيه الجميله اللي خدنا بيها زملائنا كانت ممتعه، واعتقد ان كلنا استمتعنا بيها. الواقع في سؤال وحيد بس ليك يا عمرو، جه انت ما جربتش ان انت تديها ستيرويدز الحاله دي؟
يس، هي خدت اي في ميثايل بريدنيزولون. انا متهيألي كنت كاتب ده بس it was missed وانا بقول الهيستوري انها خدت اي في ميثايل بريدنيزولون، بس unfortunately she didn't respond. يعني ما اتحسنتش قوي as regard الهيديك فريكونسي والديزنس والفرتايجو اللي كان عندها، بس بعد كده هي كملت بقى بسيمتوماتيك تريتمنت، اتحسنت اوفر تايم، بس immediately لما خدت
الدكتوره منى عامر بتقول لك اديت لها ايه للماجرين؟ تختار ايه؟
سكوبيراميد.
تمام. اعتقد كده ان احنا يعني انهينا we now came to the conclusion of the sessions. We enjoyed very much the journey of our colleagues into the connections between migraine and multiple sclerosis. Thank you very much for the speakers. Thank you very much for the attendees and for the discussion. And the mic is left for Professor ماجد عبد النصير to close the session إن شاء الله.
Thank you, Professor. شكرا دكتور أسامة. Thank you very much. And thank you, Professor Demos, for joining us in this webinar. And next time we hope to meet you here in Cairo. إن شاء الله. إن شاء الله. بشكر جميع الحضور وبشكر جميع السبيكرز. الحقيقة كان very elegant ويبينار. الحقيقة very nice. الحالات كانت جميلة جدا جدا، والحقيقة تشالنج لطيف جدا احنا بنقابله كل يوم في العيادات. فأنا بشكر الأربعة سبيكرز، الدكتور حاتم سمير والدكتور رامز رضا والدكتورة دينا زمزم والدكتور عمرو حسن. في الآخر بشكر نوفارتس. الحقيقة دايما بيبهرونا باختياراتهم للعناوين. أنا بنبسط قوي من يعني ازاي بيختاروا سلوجن لحاجه معينه. فنيورو كونكت از فيري نايس سلوجن، الحقيقه عجبني جدا. بشكر التيم نوفارتس كله على الافكار وعلى البرزنتيشنز دي. بشكر كمان طبعا لازم اشكر مصر 2000 على كان عندي بعض المشاكل في الانترنت النهارده، بس الحقيقه كانوا معايا على طول، فبشكرهم جدا. بشكر الجميع. Thank you very much. Thank you Professor Demos and see you soon إن شاء الله. شكرا دكتور أسامة، وإلى اللقاء قريبا إن شاء الله. تصبحوا على خير جميعا.
على خير. تصبحوا على خير جميعا.
سلام.
تصبحوا على خير. باي باي. مع السلامة جميعا.